good morning, everyone. My name is Dr. KUMO FATIMA. I'm a medical officer in our other branch, the LIMI hospitals. I'm presenting the second case report. So our case was a 70-year-old female. She was self-referred from a government hospital on account of chest pain of 29 hours prior to presentation. So the chest pain was sudden onset. It was epigastric, characterized as heavy burning sensation, aggravated with exertion and minimal relief on rest, non-radiating, and it was graded 9 out of 10 in pain score, and it lasted for a few minutes, then recurred. So there was associated dysphoria, that's profuse sweating, body weakness, and feeling of impending doom. There was also a history of intermittent leg swelling. She's not a known hypertensive, not a known diabetic, RVD, but she was said to have peptic ulcer. There's no family history of hypertension, diabetes, or sudden cardiac death. She has family history of hyperlipidemia, and she also has lipidemia, so she's on atorvastatin. She does not smoke nor drink alcohol. She has no known drug allergies. This was the ECG done when she went to the referring center.
Can you explain the ECG, or can somebody explain the ECG?
Does anyone want to try to explain the ECG? Me is my patient, so I know. Is there anyone that
wants to try? Anybody wants to try to explain the ECG? We're going to do ECG, and Dr. Adefila is already doing press up for chest pain. Okay, so
as we can see, basic of ECG, when you're checking the ECG, first thing you want to know is if it's rhythm or not, if there's sinus rhythm or not, and if it's irregular or not. So this patient is, it's a regular ECG, but we can see there's form of ST elevations in our, sorry.
The pointer does not work on the screen.
Okay.
So where's the ST elevation? How many people can see ST elevation? You can see it. Okay, please come and help us now. Hello, ma. Come now. Come now. Or say it. You can see the name of the lead. You give her the microphone.
Isn't lead two?
After this course, you must know what to do when you see somebody with chest pain. You must know what to do when somebody collapses. You must know how to read an ECG. You must be able to tell an ECG that is life-threatening from one that is not life-threatening. You must be able to do that. If you don't do that one, you are wasted your time. But some people will do it, so I will not waste my time. So go ahead.
Isn't lead 2, lead 3, and AVF?
Okay, lead 2, that is lead 2 up there.
Yes.
Lead 3 here. Yes. And then
AVF.
AVF. So what does she mean by ST elevation? You can see this line. Can we see this line? An imaginary line going straight here. So at this point, this place went up. Can we see that? Here went up compared to that line. Here went up compared to that line. And all the way like that. So what do you think that means?
It's isoelectric line.
So what do you think the ST elevation in 2, 3, and AVF means?
Okay, inferior MI.
Inferior myocardial infarction. And ST elevation and myocardial infarction.
So for most exams, this is like a classic ECG. They love giving acute inferior MI, where there's ST changes in lead 2, 3, and AVF. So this is what she came with her ECG from her referring center. Okay, so her presentation, we had her vitals, luckily, from her reference center too. Her pulse rate was 98 beats per minute, BP was 90/60, her random blood sugar was 11, her PCV was 21%, troponin was 0.11 nanograms per milliliter, and her ECG, as we explained earlier, ST elevations in leads 2, 3, and AVF. So the treatment given there was they transfused her with 1 pint of blood on account of the 21% PCV. Her medications were aspirin 500 milligrams and 300, clopidogrel, IV heparin, subcutaneous clexane, and tabs atorvastatin. She presented at our emergency ward, and these were the examinations found. She's an elderly woman, afebrile, pale, anicteric, acyanosed with mild pedal edema. Her heart rate was 56 beats per minute, full volume regular. Her BP was 157/96 on the right arm and 147/94 on the left arm. JVP was not raised. The apex was at the 5th intercostal space, mid-clavicular line. She had heart sounds 1 and 2, but they were distant. and she had a respiratory rate of 22 seconds per minute, 22 cycles per minute, with SpO2 of 97% on room air. She had vesicular bath sounds, abdomen was full, there was no, there was epigastric tenderness, and CNS was conscious, alert, and oriented in time, place, and person. An assessment of acute inferior MI was made. She was now sent for investigations.
Go back. Can you explain why her pulse is low?
So the heart sounds were
Pulse rate. Can you explain why the pulse rate is low? Well, because you have to sweat a little bit. Dr. Lolo, why did you run away from the stage now? Oh, yeah, come back now. If you don't know the answer, just sit down. Can you explain why the pulse? Dr. Chidera, give them mic, they're looking for you. Anybody can explain why the pulse rate is low? Okay, so one of the things to consider is that inferior MI typically correlates to the area that the right coronary artery supplies. The right coronary artery. That right coronary artery also supplies the SA node and the AV node. So when there's reduced flow in that area, it is very common to have bradycardia. A lot of times when we want to do this kind of stenting, we occasionally put in a temporary pacemaker, like the one we showed in the last one, so that in case while we are stenting, something goes wrong or some clot shifts a little. We don't give labetalol in MI. Which drug do you know, will you be afraid of? Doctor? Yes? Doctor, give them now. Why they're looking straight? Oh, Ada is here, Abby. And use your mic now. Should you have mic?
Nitrates. Nitroglycerin. Nitrates.
Okay, fine. So why we normally give a lot of nitrates to patients with chest pain? In patients with inferior MI, we want to be very wary about giving nitrates. Okay, so we typically give nitrates. Nitrates help to cause vasodilatation, increase coronary blood flow, reduce chest pain. But in these patients, if you give nitrates, you will be made to pay because they will have they could have very severe hypotension. You may not come out of it. So while nitrates are normally what we give a patient with chest pain, give a spray of nitrate under the tongue or all of that. In these particular patients, when you have that 2-3 AVF, be very careful when you want to give nitrates. Another reason why you should be careful when you want to give nitrates is if the patient has had sildenafil citrate or anything like Viagra, tadalafil, Cialis, and the like. So all those drugs that help erection, typically PDE5 inhibitors. So ask the spouse or anybody to stay outside and ask the guy, oh, anything. Tell us, so if we give you this drug and you took it. Some people will tell you nothing. Then tell them that if I give you the drug that I'm going to give you and you lie to me, you will die. Then they will call you back and say, okay, come. Actually, this is what happened. Okay, so any of those drugs, if they combine with this one, they could also cause life-threatening hypotension. You may not get out of it completely. So it's very important. So why we normally give all of these things, you should take note of those exceptions.
Okay, so in moving forward, there was an ECG done at the emergency room, and it showed a difference of changes from compared to the first ECG at the referral center. We can see the leads 2, 3, and AVF that were affected earlier have T-wave inversions. I think they're very clear. So she had an echo done too, and the echo showed mild pericardial effusion, more on the right ventricle. As he mentioned earlier, that the red circle that we have there, he said that usually the first case, it showed that the apex was having most activity. Here we can see the activity has moved towards the left side and the anterior side, whereas the inferior side has less contractility, which is in keeping with the acute inferior MI. These were the laboratory investigations. The main thing we should note is the troponin levels. Earlier, it was 0.11 nanograms per milliliter, whereas 24 hours, or should I say about 30 hours post, it was 23.17 nanograms, which also further confirms our diagnosis. And since she was on lipid lowering agents, we can see she had hyperlipidemia too. Her total cholesterol levels were 289 milligrams per deciliter, and LDL was 179. Her ESR was a bit elevated too.
So the most important things are those in yellow that we can see. Now I want you to take note of that troponin. How many people can do troponin in their center and get it maybe within 15 minutes? How many people can? Just quick raise of hands. So when you go now, you say you're an ACS graduate, Abi. You meet your medical director and tell them that you need to have the ability to have troponin done, so I can help you differentiate for chest pain. Now once troponin is greater than 0.3, we know something is going wrong. Once it is 2 times upper limit of normal, we say almost definitely something 0.6. Now, if it is 3 times, that will be 0.9. 23 is how many 100 times? 100 times 0.3 will have been 30. So it is almost 70 or 80 times the upper limit of normal. When you see troponin this high, it is almost likely that you have a total occlusion of an artery. It's not just a narrowing. The occlusion is total. So in normal MIs, you might see 0.5, 0.9, 1. By the time you start seeing 5, 6, 18, 17, 20 something, then you have total occlusion, and you have massive areas of the heart muscle wall that are necrotic, that are becoming necrotic. That is why they get so high. So this is a very, very bad prognostic sign that prognosis is poor in this kind of patients. And then you can see the N-terminal pro-BNP. We talked about yesterday. What do we say N-terminal pro-BNP indicates yesterday? Who remembers? Heart failure, Abi. So that breathlessness she's complaining about. And normal in our center is less than 300. We are seeing 2,500. So this also another very high risk case. Came in and then is already having pulmonary edema.
Okay, so she was counseled to be admitted to the ICU, where she was given IV morphine, 5 milligrams, IV metoclopramide, 10 milligrams, IV omeprazole, NTG spray, and subcutaneous clexane.
So we gave NTG spray here, Abi, because if we enter trouble, we can find ourselves out, Abi. You don't give O.
So we give tabs aspirin, tabs nicoronidil, tabs valsartan, tabs atorvastatin, and she was on continuous ECG monitoring, and she was to be booked for an urgent coronary angiogram or percutaneous coronary intervention. So usually a PCI should be done 12 hours from presentation of the pain, but since she was being referred, it could have also caused some form of complications or delay. The coronary angiogram findings, we found 100% proximal right coronary artery occlusion and proximal left anterior descending artery stenosis of 95%. So as he mentioned earlier, it means that the right coronary artery was completely occluded, giving us the signs and symptoms we've seen, the low heart rate and high
Dr. Lolo, Dr. Amina, anybody from one of the blood tests, why do you think she became very uncooperative and restless?
Okay, the NT-proBNP was suggestive of heart failure.
So she was in heart failure, right? And when we are doing the procedure, the patient is lying flat. So that heart failure is bound to worsen. As she's lying flat, after a while, she becomes extremely breathless, just like autopnea and PND, right? They become more and more breathless, so they cannot lie flat for too long. So you have to get them out of that place fast. Luckily, we did from the radial, from the hand. So it was easy to get her to sit up immediately after because we did it from the radial artery.
Okay, so post-procedure, so these are the pictures of the procedure. Just hold on. So you can see where this pointer isn't working. So you can see where the blockage is, where there's complete blockage and there's zero blood passing through from that point where the line, or the yellow line starts. And this is during stenting.
So what you are seeing here are coronary wires. The coronary wires have a diameter of about 0.014 inches. So in this case, we had to pass two wires. The first wire could not pass. We passed a second wire. The second wire acted like a body wire to give extra support. Remember, we are passing all of this through the wrist, through an artery in the hand, just the radial artery. So that's how we pass the wires across that lesion that was blocked. We are sure we are in the area before we now pass our bloom and our stent.
So this is the blood flow after the stent was placed. You can see it has completely revascularized. And because it was reversed within a short period, the muscles of the inferior heart were spared. So the post-procedure, the procedure was well tolerated. Her vital checks were stable. Pulse rate was 74, BP 130, 78, respiratory rate 22, SpO2 97% on room air. She was, however, after a few hours into the post-procedure, she was hypotensive, where her BP was dipping to 88, 53, 97, 64. So she was resuscitated with IV fluids, antihypertensives, and the nitroglycerin sprays were withheld. And she was also now put on inotropic support with dopamine. It was started at 7 mils per hour. The repeat ECG post-procedure showed no arrhythmias, no STs changes, and the repeat PCV was 35%. She had a bedside echo done. It showed mild pericardial effusion, also on the right more on the right ventricle. There was fair ejection fraction and no tamponade. Her full fasting blood sugar was 10 millimole per liter.
Okay, so quick point of note. I know there are not many interventions, but I can see some cardiology SRs here. When you try and intervene on the completely blocked artery, like this one, you know it was 100% blocked. All of you remember, we are passing our wire and we cannot see where we are going. Sometimes you may pass your wire and it may pass through the side of the artery and come out. You may not know and come back into the artery. So when you finish, blood will start entering into the pericardial space and cause pericardial effusion. And what you will notice immediately after is blood pressure crashes. So one of the things to do when you have this kind of things, to do an echo afterwards to make sure that there's no fluid. This is why sometimes some people can have a procedure, it looked, everything went fine, and then later they say something went wrong. So, but if you already know that this is the peculiarity of what you are doing, you should guard against it. You should check immediately after you pass the wire in, and then of course you saw that everything was fine. We just had to give medical management to get it solved.
Sorry. The pointer isn't working again. Okay, so an assessment of inferior MI complicated by acute pericarditis or Query-Dressler syndrome, since we saw minimal pericardial effusion, CLIPS class 2 heart failure, and possible cardiorenal syndrome. The cardiorenal syndrome was because the urinary output was a bit low in the first 24 hours. However, the renal output had increased and picked up by day 2. So this was the post-procedural ECG. The ECG shows no ST changes, no problems in lead 2, 3, and AVF, as we've seen earlier. Okay, so day 2, the chest pain had pain. Day 2 to day 4, post-procedure, the chest pain has reduced significantly. Sorry? Okay, so discharge. She was discharged on oral antibiotics and routine medications. She was placed on a high fiber, low sodium, low fluid diet and counseled by dietitians on adequate diet. She was to be seen in the clinics in 3 days' time and scheduled for the left anterior descending artery stenting in 2 to 3 weeks. She came for her second follow-up too, and this was just last week. So in the next week, we're expecting to see her for her second stenting. Thank you.
Thank you very much.